Hi, and welcome to the Perinatal Postpartum Mood Disorders introduction. My name is Samantha Green. I'm a licensed mental health counselor. I'm also a wife and a mother to two beautiful kiddos. Today we are going to discuss what is a perinatal mood disorder, what do they look like, what are some of the symptoms, and briefly how to treat some of these. Let's get started. So perinatal mood disorders, also known as perinatal mood and anxiety disorders, can occur during pregnancy and the first year postpartum. These can include postpartum depression, postpartum anxiety, panic disorder, OCD, PTSD, bipolar disorder, and psychosis. So they are very similar to what you would see not during the postpartum period or not during the pregnancy period. The big difference being is that they are centered around mother and baby. So as we kind of go through these, we will kind of see what do they actually look like? What do the symptoms look like? I think it's also important to note that these are not official DSM diagnoses. You will not find a postpartum depression like diagnosis code within the DSM, but it is something that we in the community look at. It's what we see, and it is pretty well known. So let's take a look. Baby blues versus postpartum depression. So there's three big differences when we're trying to differentiate between is this baby blues versus this postpartum depression. That is the length, the severity, and then the treatment we're looking at. So typically with baby blues, quote unquote, it lasts roughly 2 to 3 weeks. And I did note that there is a period of emotional lability, meaning that there is kind of a roller coaster of emotions that happen for several weeks postpartum. So if you're finding that you still are kind of crying out of the blue after 2 or 3 weeks, I wouldn't panic and immediately think it's postpartum depression. Like that is still fairly typical. With severity, usually it's pretty mild to moderate. With depression, we definitely see it becoming more moderate to severe. And then the treatment. So with baby blues, really it is just self-care, trying to get as much sleep as you can, make sure you're eating, make sure you're drinking water, you're being with people. Now that's also part of the psychotherapy, but they will probably look into more of like what is going on with this depression, if that's really what it is. So transitioning from baby blues to postpartum depression, we are going to see a lack of interest in the baby, feeling anger, rage, intense fear and guilt, a decrease in appetite, sleep disturbance. Again, we know that postpartum sleep is already disturbed, but this is going to be greater than typical. Significant difficulty in concentrating and making decisions, and then possibly thoughts of harming self or baby. I know those tend to be the scariest, or the thoughts of harming self or baby, and I want to differentiate those from intrusive thoughts, which we'll get to later. Intrusive thoughts are a thought that kind of pops in, what if something happens to baby X, Y, and Z? And you're horrified immediately. That would be an intrusive thought versus thoughts of harming yourself or baby seem like a good idea. So those are kind of what we typically look at with postpartum depression. For the therapists in the room or people who may be diagnosing, I think it might be important to note too, like functionally there's no difference between postpartum depression and major depressive disorder. It's just when is a woman experiencing it and kind of what is it around? Because again, postpartum depression is not in the DSM. You're not going to diagnose for it. It still would be major depressive disorder or likely single episode, and then again, depending on the severity. So with postpartum depression too, remembering that not all women experience it. Like it can absolutely look different. It's about 15 to 20% of women that will experience postpartum depression. And usually it shows up the first few weeks after birth, but it could be up to a year. So that's kind of what we look at with postpartum depression. Now, there are some risk factors when it comes to postpartum depression. The main one being, do they have a personal history or a family history of depression? If somebody had PMDD or PMS prior, they could be more likely. If they've got inadequate support for themselves or for the babies. And then, of course, all of those major stresses that we see. So financial stressors, marital stressors, if there's going to be an issue in their marriage or in their serious relationship, complications during pregnancy that include high-risk pregnancies, trauma during labor, delivery or birth, any kind of big life events, losses, grief, death, moves, women who have had multiple births, like meaning twins, triplets, etc., they could be at a higher risk. And then if your child ends up in the NICU, of course, you may be at a higher risk as well. If you went through infertility prior to having this baby, I've definitely seen that before. A lot of it comes with kind of the expectations and putting a lot on that little tiny baby. Women with thyroid imbalances, they tend to, in general, be more prone to depression and anxiety. And then any form of diabetes, so that's type 1, type 2, or gestational, we would also want to keep an eye on them. Now, just because you have one or multiple of these does not mean that you are guaranteed to have postpartum depression. That is not how it works. It's not a checklist. These are just things that we've seen that would make someone more likely to have it. So we do just kind of tend to keep an eye on women who have had one or more of these risk factors. So what's the impact on dads? We've talked a lot about postpartum depression and moms. So about 10% of dads will meet the criteria for major depressive disorder following the birth. I think it's also important to note, because I've seen this a lot, that people will call it paternal postpartum depression, but keeping in mind that dad didn't give birth, mom did, so it wouldn't be quote unquote postpartum depression, it would just be depression. And typically what we see, I know I'm jumping ahead a little bit here, but usually we'll see dads kind of coming down with depression is after mom has had postpartum depression. So if mom has postpartum depression, dad kind of picks up the slack for a little while with the caring for the baby, with caring for mom. And then as soon as mom starts to feel better is usually when we'll kind of keep an eye on dad, because that is often when he may slip into depression, almost as a response of just being so worn out, so tired, and taking care of everything that we can kind of just see that happen. Again, these are more common if mom had a particularly difficult pregnancy and birth. Again, because mom is more likely. So if mom's more likely, dad may be more likely to develop depression afterwards. So we do also want to keep an eye on him. It is also important to remember, if there are dads in the room, that their experience is much different than mom's. So if mom has a particularly traumatic labor, delivery, and birth, often they're very scared for their babies, whereas dad is terrified that he's now going to lose his wife and his child all in one foul swoop. So sometimes we will see PTSD that doesn't quite get recognized or treated. Dads often get kind of shuttled into the corner during these things. There'll be more information on that in another course. I just want to make a quick note. So let's talk about postpartum psychosis. This is the one that everyone's always scared of. When we talk about postpartum depression, most people are getting it confused with postpartum psychosis. So this is a sudden onset. Typically it is within about 4 weeks postpartum. They include delusions, usually about the baby. They include hallucinations, intense irritation, hyperactivity, significant decrease in the need for sleep, and extreme mood lability with poor decision making. So these are in the extremes too. And just because you have one or a couple of these does not mean that you have postpartum psychosis. Usually when we hear in the news of women who are harming or actually ending the lives of their children, it is usually postpartum psychosis, not postpartum depression. I know I had made a quick note about the cognitive distortions, the intrusive thoughts, not cognitive distortions, earlier. And again, intrusive thoughts are when mom is horrified by the idea of something harming her baby or herself. And with postpartum psychosis, usually those women think they're a good idea. So these are the women that we're seeing who are like, the world is a terrible place. My baby is better off dead than here, which is a horrifying thought to have. But the note is that they think it's a good idea. The good news is that postpartum psychosis is extremely rare. It only occurs like one or two out of every 1,000 live births. It does happen. There's a 5% infanticide and suicide risk with postpartum psychosis. So again, super rare. Even if you have it, the chances of something happening still very rare. If you can catch it early enough, you can absolutely be treated. You will not have to be on medication or in therapy forever. Usually I've seen it resolve itself like within 12 to 18 months. Again, that's not a hard and fast rule. That's just kind of what I've seen personally. So continuing with postpartum psychosis, there are many treatments available because it is so treatable. We do know that best outcomes for both mom and baby if they're able to stay together. Now, obviously, if mom is very fearful and thinking that she's going to harm herself or her child, this is a terrifying prospect. Many places now have mother-baby units where they are actually able to keep them together. So now at the time that I created this slideshow. There was big ones in Australia, England, and California. And they are increasing, so I wouldn't be surprised in the time that, and this was made a couple years ago, that there are more now. If you're interested in learning more too, there is a podcast called All in the Mind where they discuss all about these mother-baby units. They really are fantastic. And again, because the fear is that something may happen to mom or baby, the idea of keeping them together seems terrifying. That being said, we know without a doubt that keeping moms and babies together is absolutely the best outcome for both mom and baby. It helps resolve the symptoms of psychosis faster. It keeps the attachment better with the baby. Again, if you're breastfeeding, especially, like, you're able to continue doing that, which can be super helpful. So it really does kind of help all outcomes if you are able to do that. Again, these are very safe units where you're monitored by nurses and doctors and all sorts of support staff to keep everyone safe, but a really great option. So moving right along, there's also postpartum bipolar disorder. So this is, again, I'm going to jump ahead to kind of my last bullet over here, but women who have bipolar disorder are at a significantly higher risk for postpartum psychosis, just because bipolar often can have those elements of paranoia, delusions, and hallucinations during their manic phases. So if you have a history of bipolar disorder, if you have a family history of bipolar disorder, we would also want to know that and keep an eye out for it. And again, bipolar disorder and postpartum bipolar disorder, functionally not any different. They will experience the same, with postpartum, you're just experiencing your first episodes during that postpartum period. But again, symptoms are all the same. You will have a manic episode followed by a depressive episode, and again, so on and so forth. But the only difference being that this would happen during those first 12 months of postpartum. Now we have postpartum anxiety, which really is kind of an umbrella term because it also includes panic disorder and OCD. These include constant worrying, feeling something bad is going to happen, racing thoughts, disturbances in sleep and appetite, an inability to sit still, somatic concerns such as feeling dizzy, having hot flashes and nausea, as well as those intrusive thoughts that we have continued to talk about. Risk factors of postpartum anxiety include, of course, the personal or family history of anxiety, any previous prenatal depression or anxiety, and then also having a thyroid imbalance. I've also found, kind of on a separate note, that often people who had difficult pregnancies, whether it was high risk, whether it was just challenging, lots of stressors, again, very similar to the risk factors of depression, do kind of lead you towards a more anxious postpartum period. So with postpartum panic disorder, we're looking at recurring panic attacks, including but not limited to feeling a shortness of breath, chest pain, claustrophobia, dizziness, heart palpitations, and then numbness and tingling in the extremities. I found both working with women who are postpartum and then just people in general, a lot of people have trouble differentiating. Am I experiencing high anxiety, or is this a panic attack or an anxiety attack, as some people like to call it? And it's very hard to tell because, one, they often mimic the changes or the symptoms of heart attacks and stroke. So I often will tell people, if you're unsure if you're having a cardiac event, it really is good to go to the emergency room and get checked out, because the last thing we want is to actually having a cardiac event thinking that it is a panic attack. So that being said, there's sort of three things that I will look at to see, is this a panic attack or is this high anxiety? There's the physical symptoms, the cognitive symptoms, and the behavioral symptoms. So the physical being, of course, you feel pain in your chest, maybe you feel numbness and tingling in your body. The cognitive ones, so people either say that their thoughts are absolutely racing ahead, they can't catch them. Sometimes they'll say, like, I stopped thinking entirely, like everything went blank. And then the behavioral aspect is too, is like, what are you doing during this time? Usually people are trying to get out of whatever situation they're in because they're panicking so much. They're removing themselves from whatever room they're in. So it's, what are you physically doing during this time? Often people will say, kind of quote unquote, like, I'm having a panic attack, but they're just sitting there calmly, still able to hold on a conversation. And I'd be skeptical to say, like, that may be high anxiety, but I would be skeptical that that's a full panic attack. And again, this is not to be confused with the normal changes during pregnancy, which would include quite literally all of the things on these lists. Just because you're experiencing one does not mean it's a panic attack. Again, I look at all three of those to see, is this a panic attack? Is this high anxiety? Or do we need to go seek medical advice? And so what are normal changes? Often working with pregnant women, people will always say, like, I experienced X, Y, and Z. I asked my doctor and they said it was normal. And that's unfortunately, fortunately, because there is quite literally a laundry list of things that are quote unquote normal during pregnancy. These can include increased heart rate, awareness of breathing or shortness of breath, increased salivation, heartburn, dizziness, vomiting, nausea, dizziness and fainting, sweating, numbness associated with muscle strain, swelling, hot and cold flashes, feeling concerned about your health or the care of the child, nesting behaviors, avoiding behaviors that could harm your baby, increased frequency of urination, so going to the bathroom a lot, and then some anxiety is normal. Our emotions are a part of who we are. We do not want to get rid of them. They tell us something about our environment. So again, some is good, too much is bad. With all of these things, though, I will put the caveat on that I have a tendency to trust women's instincts. If you're experiencing one of the things on these lists, but you're like, it just doesn't feel right, something seems off, this doesn't seem normal, call your doctor, advocate for yourself. I find that, even women who don't have any kind of experience in the medical system, they know their bodies better than we give them credit for, and we can tell when something is off. Even if you're having something that we would consider as quote unquote normal in pregnancy, take like dizziness, for example, just because that's a very common one. If somebody's saying this feels abnormal, I know that some dizziness is normal, but this seems like too much, too frequent, I would certainly advocate for yourself to get checked out to make sure that there is nothing else going on. Because often I've found that women who do advocate for themselves find that there is something going on. Not to scare anybody or sound an alarmist, but we want to make sure that you're taking care of yourself and you know your body better than a book or a doctor. So advocating for yourself for sure. I've mentioned postpartum OCD several times now, so let's go over what we're looking at. These can include obsessions or intrusive thoughts related to the baby, compulsions, a sense of horror about the obsessions. Again, when I was talking about the intrusive thoughts, does it scare you? Fear of being left alone with the infant, hypervigilance in protecting the baby. Moms with postpartum OCD know that their thoughts are bizarre, but are very unlikely to ever act on them. Again, that's the big important separation between postpartum psychosis and something like postpartum OCD or postpartum anxiety, is that women will have these kind of bizarre thoughts and then be immediately horrified by them. So that is what we are looking at. Again, some women who experience OCD, I'm jumping ahead of myself, excuse me. We'll look at the risk factors next. So risk factors of OCD include the personal family history of anxiety or OCD. Again, OCD is under the anxiety umbrella. So if you've ever experienced anxiety or intrusive thoughts, we would want to keep an eye out for these as well. With the treatment, of course, being psychotherapy, so coming into therapy. Postpartum PTSD and its symptoms. So these would include intrusive re-experiencing of past traumatic events, which is usually childbirth, but it could be at any point during the pregnancy, labor, or delivery, flashbacks or nightmares of this event, avoidance of stimuli associated with the event, including thoughts, feelings, people, places, and details of the event. This often is during traumatic labor and deliveries, especially if the baby ends up in NICU or is born sleeping. Often mom and dad don't want to revisit the hospital, even if there's appointments. If baby's in NICU, it can be very difficult because essentially every time you go into the hospital, you're reliving every experience that you just had. So pretty traumatic. We're going to continue to talk about it on the next slide. Additional symptoms of postpartum PTSD include that persistent increased arousal, which include irritability, difficulty sleeping, hypervigilance, exaggerated startle response. Arousal meaning your nervous system, your sympathetic nervous system or your fight or flight system is kicked in, not sexual arousal, as well as anxiety and panic attacks and feeling a sense of unreality or detachment. That one can be super common, especially during very traumatic labor and deliveries, either because the mom is actually unconscious whether it's just the amount of trauma that her body is undergoing, so her brain doesn't remember. That a good example is when people are in car accidents and they never lost consciousness, but they don't remember a moment of impact. Our brains and our bodies protect us. So often what happens is mom will wake up, quote unquote wake up, or actually wake up and find that they are no longer pregnant, and then the baby is out and they don't remember giving birth, and this can cause a very, very large sense of unreality detachment, which is very common with postpartum PTSD. So going along with that, the risk factors for PTSD include real or perceived trauma, a prolapsed cord, unplanned C-section, use of vacuum extractor or forceps to deliver the baby going to the NICU, a stillbirth, or just any kind of feeling of powerlessness. I'm going to go back up to the real or perceived trauma, because often what can happen, especially in hospital-like settings, is that if something is going south, and even if there is no actual uppercase T trauma happening, doctors get the baby out, there's no problem. If nobody's explaining to mom what's going on, they may think that something very bad is going on. If nobody's explaining, they feel powerless, they feel like something's happening to them or their baby, and that in itself can cause postpartum PTSD, even if everybody's totally fine afterwards. Again, there's a big feeling of dissonance afterwards, that every family member looks at mom and goes, oh, but you're healthy, baby's healthy, everybody's fine, you should be fine. And because there was this perceived trauma during labor and delivery, it can absolutely cause symptoms of postpartum PTSD. Other risk factors can include, kind of like I said, poor communication and lack of support and reassurance during delivery, history of abuse or trauma, and then severe physical complications or injury related to pregnancy or childbirth. So these could include postpartum hemorrhaging, unexpected hysterectomy, severe preeclampsia or eclampsia, perinatal trauma, this could be a 3rd or 4th degree tail, or cardiac disease, cardiac issues. The list could go on and on. Again, these tend to be, I don't want to say the most common, but certainly big causes of postpartum PTSD, but certainly not the only list available. So to keep going with trauma, we're talking about perinatal and a trauma history in general. So in general, being pregnant causes memories of one's own childhood to surface. With history of trauma, these could include unresolved stress from past sexual abuse. That could be a significant component in some pregnancy complications. Pregnancy-induced hypertension, unexplained bleeding, premature, so baby going to the NICU born prematurely, or post-maturity, so being born post 40 weeks. With perinatal mental health counseling, often a big question that I get asked almost every single time is that all you do? Because I also have X, Y, or Z from my past that is kind of coming up. And it is so common. Again, we know, anybody that works with women who are pregnant or postpartum, that everything is kind of connected. So your child is absolutely going to come up as you're discussing your own child, as you're discussing kind of transitioning into being a mother or a father. You're going to be thinking about your own parents. What did they do right? What did they do wrong? Do you want to emulate them, or are we going in the exact opposite, or is it somewhere in between? So all of these things absolutely do come up with any kind of therapy during the pregnancy and postpartum period. So now that we've reviewed kind of all of the different perinatal mood disorders, what is the treatment for these? So typically these would be CBT, a behavioral action, a personal relapse prevention plan, what you would think of when we think of like psychotherapy. Slightly less conventionally, there's exercise, a solid support system, as well as just general self-care. So now with this, I personally usually do the quote-unquote slightly less conventional first, mainly being if you're not sleeping at all, if you are not eating, relatively healthy, if you're not drinking water, if you're not moving or getting out in the sunlight, it's going to be really hard to do any kind of other really kind of like cognitively based work. It's going to be hard to counteract intrusive thoughts. It's going to be hard to do cognitive restructuring if you're so tired that you can't even focus on the session. So I usually use those as foundation and then kind of move up into these more psychotherapy-based modalities. If you're wondering what a personal relapse prevention plan is, we are going to go over that next, so stay tuned. So a personal relapse prevention plan sounds a lot more formal and complicated than it really is, which is just what are your warning signs for whatever's going on for you? Is it anxiety? Is it depression? Is it a panic attack? Is it trauma? So know what worked in the past for you. Keep practicing the things that have worked in the past. Write down your anxiety rule book. So it's like identifying your disordered thoughts, again, reframing your distortions, and then starting to make those healthy lifestyle changes. Again, this is sort of circular, so while I have healthy lifestyle changes as the fifth one, we are doing that constantly, and that is hopefully the base work for kind of moving forward and recognizing, oh, these are the new warning signs, we need to adjust slightly. Again, if anybody's ever worked with me, you may know that I'm not a huge worksheet person, but you certainly could write this down in a journal, on a piece of paper, keep it close. The more we remember them, the more we are able to kind of implement them. So if it helps, certainly do it. If you're interested in learning more, I've got a couple recommended readings. So the first is the Pregnancy and Postpartum Anxiety Workbook. If you do like worksheets a little bit more, Pregnancy Brain is really great if you're going through a high-risk pregnancy. I believe she also went through fertility treatments, if that's of an interest to you. When Survivors Give Birth is a little bit more geared towards therapists and people who are looking to work with women who have history of trauma and abuse during pregnancy, have history of trauma and abuse and then are also pregnant. Tokens of Affection is Reclaiming Your Marriage After Postpartum Depression, and then Life Will Never Be the Same is a mom's postpartum survival guide, all pretty easy to read. Also, stay tuned. I do have a book coming out that I am writing on maternal burnout. So kind of what do you do with that mom rage and that burnout that we do typically have postpartum. So if you're interested in that, let me know. It will be coming out hopefully within the next 6 to 12 months. Thank you so much for joining me today during this perinatal mood disorder presentation. If you do have any questions, please feel free to reach out to me through my website. And stay tuned for more courses coming out. Thanks so much and have a great day. Take care.